Hi, everyone. Welcome to your unofficial podcast with Dr. Spain as your host and Dr. Bump and Dr. Cavinder as your guest. The three of us have many conversations regarding our careers, and we wanted to kind of take you guys along and have an inside look on our conversations. First of all, because we think we're really funny. And second of all, we think that we have some good insights that may help you guys. So tonight, we are going to be talking specifically about transition into practice. Recently in 701, we discussed tools and tips for the new grad as you transition from your student role or the role of the RN into that F&P role. So we wanted to give some details about our specific journeys and then details regarding Dr. Patricia Benner's model and looking at those roles from novice to expert, So yeah, our topic this evening is going to be transition to practice, again, looking specifically at tips and transition into that role. So we know nursing and career paths are entirely our own. So throughout school or throughout, your clinical rotations, you will definitely have people that you look up to and say, I want to be like that person and kind of want to follow their journey, but it's always going to be our own roles. So it's a personal path. So Dr. Cavinder, Dr. Bump and I are going to give you details about our career paths that have led us to where we are today and try to talk about advice that we have for you. I think you guys know me pretty well, so I'm going to kind of skip over myself. And then Dr. Bump, I see you first. You want to kind of give us a background about where you were as an RN, what you're doing today, and kind of how you got there.
So let's see, I graduated nursing school from Babo in 1995, December. So I took my licensure exam in January, and I started out on a telemetry unit and then transitioned into the intensive care unit. And so pretty much did critical care for most of my career. In 2003, I had the opportunity to get trained in quality improvement and performance improvement as a Six Sigma black belt. And so I left the bedside for a number of years and worked within the quality department doing QI projects. First at Franciscan, Northern Indiana region, so across at the time, the 5 hospitals, doing projects such as some of them were clinically based, so ICU length of stay, pressure ulcer reduction, and then others that weren't, so central scheduling and then billing. We did projects on. So I then went from Franciscan to Rush University, where I was still doing projects, but I was also a quality consultant to various medical departments. So neurosurgery, neurology, critical care, and then overall the entire cancer program, helping them with their accreditation. So for the bone marrow transplant, for instance, at Rush University, getting their FACT accreditation. And then also dealing with core measures. So looking to make sure that our processes of care were meeting those quality outcomes that are publicly reported. And then even to like the details of like abstracting medical records to get at that data, but taking that step further to get the organization to actually make improvements. And we did, we got to a 94 core composite, which is really good for an academic medical center. So then I was, this is a long story, I'm so sorry, but this is like 20 years worth of a career. So then when I was in quality, I had a really awesome vice president that I reported to. And she made it part of my evaluation for my job to go back to school. And she had her PhD in nursing. And so I originally went along the path of health systems management, which is very similar to our health admin master's program here.
Right.
And I took a couple courses, and then, she just finally said to me, you need to get your DNP. You need to be an expert at nursing.
Right.
So I listened to her, I guess. I don't know.
Smart woman.
And then I went back, I went back to Valpo because, I still did microfiche and looked up the Dewey Decimal System to do my research. It'd been that long since I had been in, really in school. And so now everything's on the computer, and I was a little freaked out. So Valpo, at least I knew, like, it's a home base for me. And I started slow, one class a semester for the first year, and then I went full time. And as I got into the clinical courses, I pulled away from because my goal was to be the director of quality, the vice president of quality at Rush. And that's where they were kind of pushing me toward. But at Rush, you have to have an advanced degree to be in a leadership position. But then, I just got so kind of in tune with clinical again. So I transitioned into a clinical role in the neuro ICU at Community while I was in my MP program. And upon graduation, got a job within cardiology, doing inpatient and outpatient management within that specialty, and then hospital medicine. And then now, of course, I'm in the intensive care unit at Community doing intensive home critical care. So that's kind of my journey.
Awesome. Thanks for sharing. And there, see, even though we talk so often, there's things that I didn't know. You know what I mean? So I don't think we talk specifically about how we got to where we're at. So thanks for sharing. Dr. Cavinder, can you give us a little background on yourself?
Sure. I'm not as impressive as Dr. Bump.
Oh, whatever.
The lady dealing with tiny little humans all the time.
So I actually, when I graduated with my bachelor's, it's in cellular biology, and I worked.
You're not impressive.
Right.
I worked for Indiana University because that's where I went to school in Bloomington, in the research department, and I worked with the research animals. So I don't know if anyone's with PETA out there, but they were well cared for. And actually, they were better cared for than our patients. I always complain about this because the mice that we had mice, chickens, rats, and rabbits. And because of experiments on them, we had to keep everything as a control. So their temperature never changed in the room. Humidity was always the same. Lights went on at a certain time, they went off at a certain time. And you go to the hospital and you're freezing. You're like, what? We can do this for rabbits, but we can't do it for people. But anyways, that's another story. So I worked there, and I was the only woman there. That was different too. And I liked it, but I just, after a while, when your best friend's a rabbit, you got to move on, got to find something else to do. And so it's kind of a choice between going to graduate school for biology or going to something else. But I didn't want to work in a lab anymore. I just didn't see people very much. Right. And really, the lab is very monotonous. You're doing the same thing every day for months. And so it just got to be like, I don't want to do this. And I worked as a nurse assistant in a nursing home in high school. So I thought, oh, I'll do nursing. So I went into nursing. I went into, again, another IU, but this one in South Bend, because I'm from Northern Indiana. And I got my associate's degree there because I didn't want to go for another 4 years. So I got my associate's degree. That was 1991. And then I started working in the newborn intensive care right out of school, which a lot of people will say, don't work in intensive care right out of school. You should work in med surg. That is not true. Don't work in something you hate. If you don't like med surg, don't do it. I mean, it's not true. We take new grads all the time in the NICU, so don't do that. So I worked in the NICU for 8 years. I also did pediatric home care at the same time. Most of the cases I worked on were babies that had gone home from our unit, so I already knew the family. So I decided I wanted to do something else, and 2 college degrees wasn't enough, so I went back to school, got my master's degree, and I got a pediatric nurse practitioner. At that time, there was a couple benefits to doing that. First of all, if you went to school in the state of Indiana and then you worked in a low, I guess it's low economic county, which I can guarantee you most counties in Indiana qualify, they would pay off your student loans. So when I was in my master's, I actually paid off my undergrad loans. And then when I finished with my master's, they again paid for my loans as long as I worked in the state of Indiana. So that was nice. But the state of Indiana did not at that time have a neonatal nurse practitioner program. The only pediatric nurse practitioner program was at IU again. So I went to IUPUI in Indianapolis. And back then we didn't have Zoom or anything fun like that. We had IHETS, and I don't even remember. Do you guys remember what IHETS stood for? I don't know. It was a distance learning thing, but you had to be in the classroom and then they would program from another campus. But I had to go to Indianapolis once a week. And I can tell you all the malls from Indianapolis to South Bend because I hit them all because I was tired of sitting all day in class and then had to drive home 3 hours. So yeah, we didn't have that distance stuff like you do now. That's how old I am. So then I got my master's degree and I was planning on working in a clinic. So when I did my clinicals, because my master's is in pediatric primary care. So I was planning on working in a clinic. But as I did my clinicals, I really didn't enjoy. I mean, I enjoyed the kids a lot. It was just earache, strep throat, earache, ear infection, strep throat. I was just like, oh my God, I can't do this every day. It's not very exciting.
You're back to the mice and rabbits.
I know. I was just like, oh. So when I finished, the medical director in the unit that I worked at asked me if I would work as an NP in the NICU. So I was not a neonatal nurse practitioner, but I did 6 months of training in the NICU to learn all the procedures. So at that time, I was the only pediatric nurse practitioner, which it actually was good because I could actually go up to peds and do things in the PICU or peds. Okay. That it really helped out. So I did that. And then I worked in the NICU at that hospital for 26 years total. And then I just was getting, it was a little bit much because we did transports. So we did helicopter and ground transports. Wow. It was great when you're 20 and 30, but when you're hitting your late 40s, you're like, I cannot, it took forever for me to recover. And I always worked 3 12s in a row. So nights and yeah, it took a lot out of me. And then, I got married, started having kids. So it was more of a challenge. So I decided that I still wanted to be at the bedside. I still loved what I did, but I thought, well, maybe I'll teach. And so I taught at Bethel College for a year. Wow. I enjoyed that, but I was just filling in for someone. They were gone for LOA. So I had just 1 year there and I really enjoyed it. So I thought, well, maybe I'll go teach. So I didn't think I'd get a job at Valpo. I applied and I actually was going to go get my doctorate then, my DNP. So I applied as a student to Valpo and I also applied at Vanderbilt University. I actually got accepted to Vanderbilt first, but I thought, well, if I get a job at Valpo, then they'll pay for my tuition. So once again, I'm going after people paying my debts off.
Hey, it's smart.
Yeah. I wish I should have talked to you. I should have talked to you.
Yeah, I was, and I don't think they have that anymore with the state of Indiana. If you go to school in Indiana and then work in Indiana, that they'll pay off your student loans, but it was great back in the day. Yeah, nice. A lot of people did that. So I got accepted at Valpo. I also was offered a job there. So I did both. I backed up to part-time at the hospital, but it was still really tough. I love night shift. I really do. It's just nicer. You don't have as many doctors. You don't have as many family members. It's just
or administrators.
Exactly. So it's a little more laid back on nights. But I mean, it wasn't like being on med surge where people are sleeping. I mean, the babies eat every 3 hours, whether it's night or day. So you're still doing the same job that day shift would do.
Right.
It kept you awake. So then a physician from Porter and LaPorte Hospital called me out of the blue. And she's like, are you looking for a different job? I'm like, well, I have two. I really don't want a third one. And so I talked to her, and it was a smaller unit, less stress, not as many transports, and it was more money. So I said, sure, sign me up. So I quit at the other hospital. So now I cover at Porter and LaPorte hospitals for my bedside. I don't know if I could give up my bedside. Both the university and the medical director have asked me, like, why don't you quit there and just work here? And I'm like, I like them both. You know, they both have good things. And I can leave the bedside. I like the bedside. So
Yep.
I feel the
Right.
same way. I feel like, I mean,
Yeah.
I know as faculty in the FNP program, we're required to do some clinical hours, but I can't imagine leaving the
no,
bedside.
I
I don't
can't.
know where I get all my stories from.
I know. I know.
Yeah, it does help when you're teaching to, say, oh, this is what happened to me or whatever. And I did for a while work at a clinic. It's a low income clinic in Elkhart County with the health department.
Mhm.
And so I got to see the older kids, but it wasn't as much. So I could see ear infection, strep throat, but it was only one day a week, so that's okay with that. But the governor cut funding, and the governor, I won't say names, but Mitch Daniels, cut funding for that clinic. And so it had to close. So I don't know where those people go now for healthcare, because they don't have primary care providers and they can't afford, we were not Medicaid. Medicaid, you could go to a physician. We were the in-between people. Like, they made too much for Medicaid, but they didn't have insurance. And so that's what the clinic was for. So it's kind of sad that it's closed now.
Yeah.
Yeah.
Well, thank you for sharing. I think all three of us, definitely from our conversations too, we definitely still love being nurse practitioners. I mean, we're very happy being faculty members and love that role, but all three of us definitely still love taking care of our patients. And I agree with you guys. I could not imagine not doing that a day a week or whatever, because I truly still get enjoyment out of it. It's interesting too, listening to you guys. And again, I found out new things about you as well, Dr. Cavinder, that I wasn't aware of, but I think, by luck of the draw or whatever, we kind of have in our own roles, kind of led the path for future generations. I know for me in my previous job, I was, to my knowledge, the first nurse in the entire company of like 270 some plants to be in management. So that was really cool. Like, they'd never had a nurse administrator. So when I was the first NP that actually, a lot of the other clinics, they were contracted out, or they would have RNs working, doing the workman's comp, but I, to my knowledge, was the first one to become management. So that was neat. And then it sounds like with you, Dr. Bump and Dr. Cavinder, you guys were kind of in your area, the first nurse practitioner, potentially. Dr. Cavinder, you said you were the first one in the, working with the pediatric or with the neonatal group, right?
They had neonatal nurse practitioners already. The ones that we had were only one. I think there was 7 of us. There was only one with a master's degree. All the other ones were certificate, which means they went for 3 months to school.
Okay.
And then they came to the unit and did an internship for 6 months. So they basically had 9 months, and then they were at NP. Those programs no longer exist.
Okay.
In the state of Indiana right now, it requires you to have at least a master's degree or you're grandfathered in. So right now they can stay, but they can't go anywhere else. If they tried to go to a different hospital, they wouldn't get hired.
Okay. Interesting. And then Dr. Bump, I know with your current role as intensivist, you were one of the first NPs, am I right? Correct me if I'm wrong, for that hospital system, right? That took on that role? Or tell me
Yeah,
more.
they had it. So during COVID, they started using NPs in that role. Community had an open ICU, so meaning that any internal medicine physician, if their patient went to the ICU, could manage their own patient within the ICU. And, all of the research and evidence, not to get into like too much detail about all that, but supports the use of on patient outcomes, the use of a closed ICU where only an ICU trained physician or provider is managing those patients while they're in the ICU. So right around COVID, they transitioned to that, a lot of internal med doctors weren't wanting to round in the ICU when COVID.
Right.
So it was their opportunity to kind of implement this program. And not that it's the first. I mean, these programs exist and have existed for decades at other areas of the country and other hospitals. But for our, Northwest Indiana community, that was their opportunity to kind of put that model into place without totally angering the entire medical staff.
Mhm.
So they did that. And when they did that, they wanted night shift coverage, so that one doctor who's on for the week wasn't then also getting all the telephone calls for all the critical care patients. So they started using NPs. And so they had a couple of NPs who were working like intermittently. But when I started, we kind of further developed the program so that all night shifts were covered. And now we're looking at building that into a 24/7 model with advanced practice providers.
So cool. So cool. It's really fun to watch these programs expand with the role of the nurse practitioner, and see how, again, we're all nurse practitioners, but see how we're all so different and experts in what our chosen field is. So it's really, really neat. So kind of transitioning to our next topic, I would like to hear from you both about your specific transition to practice from that RN role to the nurse practitioner role, and talk about any barriers that you may have faced and any emotions that you felt in that role. So Dr. Cavinder, I think we'll start with you this time.
It was rough. It was really rough because I was working in the same unit that I worked as a nurse. And so the nurses, they didn't really see me as knowing anything. They kind of would come up to me and they would say, this is what's wrong. And they just want to call the physician, but that's not what we did. You told me, and then I filtered through what needed to go to the doctor or not. And there were a few nurses that did not, like if the physician came to see a patient, they'd be like, oh, okay, I'll help you. And if I came to see a patient, they would get mad because it wasn't a good time for them, even though they're right there taking care of the baby. I'm like, really? And I'm like, well, I have to see the patient, so you're gonna have to step aside. So so the first couple of years were like that. And then it was hard for me to move away from doing one patient's care or two patients' care to now I'm over everybody, and our unit was big. It was 36-bed unit, usually full. And so it was just me. And so I had to walk around at the beginning of the shift and see each patient to make sure I had eyes on them at least once. And it's hard when the first night I would be there trying to keep track of who's eating what. I mean, we had a report sheet, but it wasn't always up to date, and who's eating what. And I don't know if you guys have had this, but I'm really good at remembering numbers. So I would remember, okay, that baby's on 13 milliliters of feeding, that baby's on 25 mils. And the nurses would come up and I'd be like, they tell me about a feeding or something. And I said, they're on 25 mils, aren't they? And they'd get out their report sheet, and they'd be like, it's like, you have two patients. You can't remember how much the baby's eating. I can remember, and there's 36 that I have to remember, but yeah.
Oh my God, you remind me of the cardiologist I worked for. He would like name a patient and I'm like, I don't remember that patient. And then he could like tell me what their echocardiogram looked like, oh, their LV function is blah, blah. And I'd be like, how do you remember that?
I can remember numbers really well. Names, I'm not good with names, but numbers I can remember. So after that, it started to get better. I mean, they saw me more, but the physician, the medical director at that facility was very, everything goes through me. I want to know everything that's going on. You can't make a decision. I'll make the decision and tell you. So I was always like, why am I here then? I felt like I was just there for procedures. Like he didn't want to do procedures. That's what I did. Or I'd look up all the history for the H&P. But yeah, he'd have to okay everything. And I remember the last night I was working and he told me, well, I've got an admission. He says, start the IV fluids at 80 mils per kilo per hour. And I said, really? I've only been doing this for 26 years. I think I know how to start the IV fluids. And he was like, what? You know?
That's funny.
Yeah, I was like, oh my gosh, I can't believe you're telling me that. And now
Are
we're
your babies even, do they even weigh a kilogram?
some of them, not all of them. But yeah, now where I work, it's totally different. Like I'm on and I do have a backup physician, but I make all the decisions. The only time I call them if it's super critical patient and they need to know about it, or I have a question about something. And it's just refreshing because they really trust me. When they talk about a change in the unit, I'm included on that. Where I worked before, the nurse practitioners were never included on anything that went on in the unit. Any policy change, anything like that, we were never included. And now, it's nice to have the physician say, what do you think? I'm like, oh my God, they really want to know what I think. So that's very refreshing.
That's nice.
And it was easier to go there just because people didn't know me. They didn't know me as a nurse when I went there, but I'm the only nurse practitioner there. There's no other nurse practitioners there. I'm the only one.
That's what I was just going to say. What a unique transition, because and I think there'd be some benefits because you've already gained some respect from people, but then also like you were talking about that role confusion. So 2 weeks ago you were an RN, and now you're a nurse practitioner. Like, wow, you know what I mean? I think people may have trouble grasping not only the role, but like how, I don't know, just what the difference is or how, you know what I mean? How to approach you after that role transition has happened. So that's a unique experience, I think. Again, probably some benefits, but probably some barriers to that as well.
Yeah, the thing I'd hate is that I don't get to do some of the bedside stuff, but every once in a while, if I'm not busy, I'll give a bath, I'll change a bed. I'll do all that. I mean, I still like doing that stuff. So I don't feel like I'm above that, It's interesting when we teach the sophomores about, how to give a bath or, that, and they're like, oh, the aides.
That's the nursing assistant.
I know the aides do that. And I'm like, okay, well, I'm just practitioner. I still do it.
Yes. And that's an awesome time. Well, your patients probably don't talk to you much, Christine, or but it's an awesome time to really get to know your patients and really know what they need or what they're feeling. I always say that I miss being a PCA probably the most, like I love my job, but that was when I felt like I really was able to connect with patients because you had that time, so. Well,
and it's a fabulous time to do your assessment, they're naked, you look at all their skin and everything. So yeah, I don't know. I don't understand that mentality where they think, well, I'm a nurse, so I don't have to do that. I'm like,
yeah.
We all still do it. We all still do it.
Mm-hmm. In your role now, and now that you've been practicing for quite some time, any specific barriers like with either the nursing staff that you can think of, or even with the physicians, with people understanding what your role is, or do you feel like you've kind of conquered that?
I think I conquered it pretty much. Sometimes the physicians I have a little issues with because they are comfortable with what I do, but I'm only legally allowed to do certain things. Or, if the baby's really, really critical, technically the physician is covering me for that. So in the state of Indiana, if people don't know, you have a backup physician as an NP. Now, some states don't require that. You can practice without it, but in Indiana, you have to have it. And so sometimes I've had some instances where, the patient's really bad. And I've called my backup physician and I'm like, you need to come in. They're like, no, you're all right. You got it. Like, oh, legally, you have to be here.
Right.
know? So that's probably the only issue. But the nurses always treat me with respect, very nice and everything. I did have an issue, though. One time we have Valpo students coming to our unit. And one of the students called me Dr. Cavinder. And because that's what the students are supposed to do. And the one physician, he said, oh, so you're a doctor now? And I said, I have my doctorate. And he goes, oh. So yeah. I think he thought I was trying to say that I was a medical doctor. And I'm like, no, but I do have my doctorate. So
right.
Yeah.
Yep.
We
Dr. Bump and I
earlier today.
We were. That's what I was just going to say. We were talking about that earlier. So, and yeah, when I'm in the clinic, I just refer to myself as Scarlett, but you know, and it's always kind of awkward when people call you doctor and I'm like, no, I'm a nurse practitioner. Then they say, well, you're like a doctor, you know, and then just educating people the differences and you know what I mean? Because we want to be specific about, it's good for our role too. We need to elevate our role and be specific
Well,
about how
I'm
we,
better than a doctor, you know, because a doctor's not going to do a bath.
right, right. Yep.
So I'm better.
Yep. Yep. Well, I think it does elevate our role. I think by just, again, talking specifically how we are different and trying to clear up that confusion, but it can be very confusing. So,
Mhm.
all right, Dr. Bump, any specific barriers that you faced and talk about your emotions with, at the time or with those barriers from going from that RN role to the NP role?
Oh, so I think I share this with students, but I'll share it again. And I know we've talked about it before, but so I was like a nurse and then in quality for, I don't know, when did I go back to school? Well, I got my MP in 2015. So my DMP in 2015, I started working as soon as I graduated. So probably like May, June-ish. But I had been an RN since 1995. And when you talk about the Benner model, so, you know, I'm an expert, you know, I just show up to work in the ICU. And, you know, like I remember the nurses I was just very, always calm in the room, you know, like, oh, you want to know how to do CBI? Okay, let's show you this. So then I'm in the NP role and it was frightening. It was a lot more difficult of a transition than I thought it would be. And not that I knew how these patients were managed in the hospital. I saw it every day. I carried out all of those orders, but to be the one like going through all of it and making the decisions. So I worked with this really awesome cardiologist and I was rounding with him one day and, you know, I'm sitting at the computer pulling up, you know, he wants to see the echo and the images and patient was in atrial fibrillation or whatever. And he's like, so what do you want to do? And I'm like, oh, what do you want me to order? I'm sitting at the computer ready to enter in his orders, right? And he goes, no, what do you want to do? And I'm like, well, you're the cardiologist. What do you want me to do? Like, and so he pulls up and Scarlett, if you can find it, it would be funny to probably put it within this podcast, but he pulled up Coming to America and the scene where Eddie Murphy is being introduced to his arranged marriage wife. And he's asking her what she wants for dinner. And she's just like, whatever you want. Whatever you want. And so that's what he was like making fun of me. He's like, you're the provider now. You have to decide. So they had to push me, you know, at least when I was with them. When I was rounding or alone with patients, I was like, oh, fake it till you make it.
Yeah.
It was really rough. And so when they talk about, because I know we had a lot of discussions when I was in the program about people who go straight through from their RN to their NP, and then people like myself who wait until they're old ladies to go back. And, you know, I remember thinking like, well, how you don't know so much, like, how could you do this? But I think that transition's probably not as difficult. I mean, I'm just guessing. It's not my personal experience to share, but I would have to say that there might be different challenges than what
Yes.
I faced.
Yes. So going through kind of from high school all the way through, trekking through, I would say was different barriers. And of course, this is going to vary by person to person. But for me, I mean, I felt comfortable in my role, but you're right. I mean, I felt comfortable dealing with patients and listening and my assessment skills and, you know, looking at differential diagnoses and that kind of stuff. But there is some things that you haven't dealt with, you know what I mean? So it's going to be limited on your code experience and that kind of stuff. Almost like I would say that muscle memory stuff. Like I remember in my first job in internal medicine, trying to, you know, draw labs on somebody. And finally the guy's like, it was actually my father-in-law. He was like, okay, you've poked me enough. And it's just because I didn't have that experience, right, of being able to do that. So I would say things like that, you're probably lacking in. But yeah, I think everybody's role again is going to be specific to however they do it. And it's definitely obtainable, and just making sure that they've got the right support, also for people, making sure that you have a collaborator, which is what Dr. Cavinder was referring to in Indiana. Right now, you have to have a collaborator. So this is going to be a signed agreement that's sent down to the state. The big thing with your collaborator is that they have to review 5% of your prescriptive charting. So like me, I practice very independently. Like my collaborator is not on site with me. I maybe see him literally once a year, but all my prescriptive charting, I will send him a list. Like I did a prescription on this person per month. Then he'll review those charts. And then of course he's always there if I've got like a question about whatever. So yeah, making sure that you have a supportive collaborator, and not only your collaborator, but also other NPs or mentors that you can ask questions to. And, I ask questions to these guys all the time, whether it's about patient care or, state regulations. Like Dr. Bump and I were talking about that the other day in regards to, I forget what we were talking about, rounding in the hospital and co-signing or something like that. So yeah, just having people there that you can ask questions to is going to be really important. So we did this week in class, we talked about Dr. Benner's novice to expert model. So I wanted to see if you guys have any specific thoughts, or if you remember, kind of going through that model. So I know again how, and they have examples like, this may be year 2, and I don't remember off the top of my head where you feel this way or whatever. Any thoughts on that from either of you guys, how you transition from that novice to beginner, competent, proficient, expert in your role?
I feel so I must be pretty comfortable with this, going back to novice and up. I don't know if I would call myself an expert at critical care just yet, but I do think I'm proficient. Because, I had to do that with cardiology, and then I leave cardiology and go to hospital medicine, and I start all over. And yeah, you bring stuff with you that you can use, like from cardiology. Well, I know how to manage chest pain, and I know how to manage, heart failure and atrial fib, but now I have pneumonia and sepsis and these other conditions that I've never been in charge of, like diagnosing and treating. And then now in critical care again, having to start 2 years ago, whatever, having to start over kind of at a novice role again. Or at least a competent role, I guess.
Right.
So, I mean, you have to be really immersed in self-educating yourself and looking things up, and forming those alliances like you mentioned. And while they aren't always nurse practitioners, like I have a GI doc that I can text any time of the evening.
Yep.
I have, my pulm critical care guys. I still have my hospital medicine physicians that, at any time I can ask a question to. And I definitely have like a nephrology, right? So, and you develop those contacts and those relationships with those people so that you are reaching out to them. And so I don't necessarily think that it's going to be exposure to different situations, different patients, different conditions that ultimately gets you to a proficient level. But it's also about being totally engaged in that learning process.
Yep. Agreed.
It
Dr.
doesn't end with school.
No.
It never ends.
No, it doesn't. And because management changes often, you know what I mean?
Mhm.
So yeah, it really doesn't. And not only medical management, with my role specifically, I have to know like OSHA and be up to date on policies. And with my old role, I used to actually write policies related to new OSHA standards. So yeah, I mean, everything's constantly changing, which is good because we're trying to provide the best outcomes for our patients, right? So, but yeah, it's definitely an ongoing learning process. Dr. Cavinder, any thoughts on that?
I think I think when I first started, my patients don't talk, so they can't tell me when they're in pain,
Right.
or they can't tell me if they don't feel good. So you really get good assessment skills. I mean, you've just got to know what to assess. If you find a finding and you're like, okay, now I got to assess these other things based on that finding. I think that takes a little while to do, because you have to think it all through, like, where you have your differential diagnoses and this is what I need to look for and everything. And I think sometimes the nurses think that, they come up and they'll say, tell me an assessment thing or something. And I'll be like, and, I'm like, okay, you found that. So what did you assess based on that? And they'll always be like, what do you mean? Not all of them, but the relatively newer ones. And you're like, okay, think about what that is. And then think about, what else should I look for before you come to me? Because, I'm going to ask you all these questions. So you need to anticipate those. But I think when I first was a nurse practitioner, the first code I went to was horrible, because I had never led a code before.
Right.
And so I go and it was shoulder dystocia where the body was trapped for like 20 minutes, so they, at 6 doctors in the room, they're flipping the mom all over trying to get the baby out. It was just horrible. And then, like every nurse was in there. I mean, there had to have been like 20 people in the room.
Wow.
And then when the baby comes out, it's me. I'm the one that's saying, okay, we got to intubate, put in a line, give epinephrine, we're doing all this stuff. And, things are not going well, baby's not improving. And then I called my collaborating physician and this isn't funny, but yet it is. I'm on the phone with them. Now 20 people are staring at me like, what are we doing next? And he's going, well, how long have you coded for? I'm like 10 minutes. And he's like, and no heart rate. I'm like, no. And then he goes, studies have shown that babies that come back after, and it's like, really? It's a yes or no question. Keep going or no. Keep going or no, and I'm just like, okay, yeah, that's great. I'm just like, so then he's like, are you comfortable calling it? And I said, well, I can't. Legally, I can't call. We're done. And he's like, we'll have one of the physicians do it. And the one physician's like, sure, I'll call it, but he wouldn't talk to the mom. So now it's my job to talk to the mom and tell her about all this. And that was really rough for me because I'd never had to lead a code. And now, it doesn't bother me as much because I know what to do next. I know what's coming and what to do and everything. So I think that was a really hard transition for me just in those cases. But yeah, I mean, everyone goes through that when you're first a nurse practitioner. And I always tell people, like we get new nurses and they're like, well, you didn't tell me that was a possibility. And I'm like, okay, I can't tell you everything that might happen or what you might see because I've been doing this 31 years and there's still stuff that I've never seen. I've never seen Siamese twins, which will probably now happen because that will come out of my mouth and my work will have Siamese twins. But, and I don't want to see Siamese twins. I'm just saying, I haven't seen everything. So that means you haven't seen everything and I can't tell you everything that's out there. To me, it's great because I learn so much when something happens that I've never experienced before, but other people find that very anxiety producing.
Yeah. Yeah, it's the role in itself. I mean, and I remember, I don't want to go too much into detail, but unfortunately there was a handful of fatalities in my 8 years at my previous job. And it would be my responsibility to see, a partner that was with the fatality from the day before. So to kind of look at mental health status, see if sometimes they would have been close enough that they had injuries as well. And that was so difficult for me. Just because a lot of times these people would be partners and working together in the field for 20 plus years, and then they literally would see their partner be killed in a workplace accident. So really, really hard, or talking to family members, and something that I didn't fully ever even think about until the first fatality. And then I realized I am going to be involved in this, whether, obviously we wouldn't see really bad injuries in the clinic. They would go straight to the hospital. But if people did, even the severe injuries, we would see them as follow-up. So, I mean, there was just a lot of mental a lot of mental stress with that as well. So yeah, it's you can't ever be fully prepared. But I think again, just having a good network too. And some days, and I'm sure after your story, Dr. Cavinder, I'm sure that was stressful for you too, and something that you needed to
Oh, yeah.
talk about when you left, just thinking like, oh my gosh, and not saying that you didn't, but could this have went another way, or just second guessing yourself, or even not even that, but just thinking, I don't know, like, I mean, that's traumatic for you as a provider as well. So do you guys have any thoughts on that? Like, what do you guys do to decompress, or after you've had a really stressful day, or dealt with trauma yourself from a workplace death, or whatever it looks like?
If I'm still in the unit, like it happens and I still am going to be there for a while, I usually go and hold a nice baby, just to give me that warm cuddly. I'm like, okay, I just need a little touch here. But usually I think for those code situations, we usually debrief, and that always makes people feel better. And then when I get home, I try very hard to leave home stuff here. So when I go to work, I'm not dealing with that. And it's the same with that. I try not to bring that here, but I'm sure if you talk to my husband, I'm always calling him saying, you won't believe what happened, but yeah, no HIPAA there, right?
Right.
But
Yeah, you didn't name anybody.
you just try to find something that you enjoy. And, I just find going over what happened so we can learn from it and talk about it. And, I try to do debriefings with the nurses so they feel more comfortable, because they're always super frustrated anytime we have a death or something bad happen.
Oh, it's traumatic. I mean, it's stressful, especially with an infant. I mean, any death is terrible. I'm not discounting that, but yeah, that's like a unique situation in itself.
Yeah.
So, Dr. Bump, any thoughts on that?
I don't know if we just become so hard being an adult intensive care unit nurses. And plus for most of my career, I've worked in community settings, hospital settings. So when we talk about, we're not doing bone marrow transplant on like young patients who are dying, everybody, for the most part, the deaths that are occurring in the adult ICU are older, chronically ill patients. A lot of times you could see it kind of as like a relief for them. And then we also just develop, really, I don't know, you get kind of hardened to it over time. And I mean, that's just as a nurse in general. I would say the first time that I really had a hard time was during COVID, when we were having more young people dying. And I talked to everybody about it. The nurses, we talked constantly about it. Like Christina said, or Professor Cavinder said, the debriefing is important. I don't know that we do enough of that in the adult ICU. We should do more.
Yeah. And I tell the nurses, anytime you have something happen, and maybe it's not a life or death, but anytime you have something happen that you feel like you need to talk about it, we can debrief, get everybody together and we all learn from it.
Yep. I think that's such an important aspect of this, and just thinking about myself, and I don't do this as much, but as a new grad, I mean, I was just because I am very type A, I would say. And I'm a worrier. So sometimes I'm like, man, I'm in the wrong field, because I literally was that NP that would call and be like, hey, so that antibiotic I gave you, how's your leg looking? Like, has the redness gotten any worse? Like, and they'd feel like, oh, you're the only person that's ever called me at like 8 p.m. And I'm like, I'm just a crazy person. But I don't find myself doing that as much. But yeah, just I think it is so important just to talk about these things with people, and to know that those feelings that you could have of, I guess, insecurity, just speaking for myself, are normal, in that you just work through it as time goes, and knowing where your role is. And that may be kind of a unique experience too. And I know we all have different personality traits, but one of those more unique experiences from going straight through, you know what I mean? And not having a lot of nursing experience. I don't know. Or maybe I'm just a warrior, which I've been that my entire life. So
I think it's also, I think it's personal, but I also think it's not even necessarily that you go straight through. I think that area of nursing or your nurse practitioner experience also informs kind of how you respond or react to things, you know? So, I mean, I have nurse friends who have worked med surg, and really, I mean, the times that they've been involved in a code have been hugely impactful on them. And
Yeah,
they are just like shocked that, I guess I compartmentalize well. I don't know. It's probably a total defense mechanism, but when you, especially during COVID, when we were having like 4 people die a day or whatever, I mean, you can't, I mean, I'd have to leave that area if it destroyed me,
right, right.
So, and that sounds hard. I feel like I'm really engaged when I'm at work, very engaged. Even when I'm like, oh, I have this patient who has metastatic cancer. I can't believe that, their family aren't to the point where they want to just do comfort measures right now.
Right.
But with them, I'm like understanding and very engaged, but then, I'll go home. I don't think about it. I go next week and I'll have somebody ask me like, oh, what happened to that patient in 11? And I'm like, what patient? Like, I don't even remember. I mean, and I'm sure it's a defense mechanism
How
or
interesting.
just early dementia. I'm not sure.
That's interesting though. Have you always been like that? Or do you think that that's something that's
No,
developed?
I mean, I've always been that as an ICU nurse, I think. I just, yeah, Scarlett, even, or gosh, now I'm getting a little personal, but I mean, even with my dad's death, and I was there at the hospital, I started cleaning the body up for the rest of my family to come see him. I mean, I just went into nurse mode.
Right.
So I think it's just that whole defense mechanism
Yeah.
that you develop because you're around that kind of incident so frequently.
Yeah. How interesting. And again, I don't know enough about, different personality traits or if that is a defense mechanism, but that's very interesting. And again, I think that's probably, I don't know, it's got to be related to things that you've seen or ways that you've felt. And I don't know if it's a bad thing, a good thing, or neither, but that's interesting. I'm glad you bring that up because it is different to my experience, of kind of always having things in the back of my mind. And I would say I have more trouble letting go of work at work. I also, with my old job, was on call half the month. So it may have been that as well. So, like I was constantly carrying a work phone around and getting calls even like on vacation, you know what I mean? So I don't know if that's what kept me ingrained, and being that we had 2 providers. So with that huge industrial setting, there was like 5,000 people when I started. By the time I left, there was probably about 3,600. We were the 2 providers for everything. So we got to know them on a basis where, I was taking care of if they had burns, I was taking care of their wounds every 2 days and doing their surveillance exams every year. So I was constantly in that role, if that makes sense.
Yeah.
So yeah,
So when I did quality and performance improvement, I couldn't leave work at work.
right.
I was constantly doing my projects and doing email and writing policies and looking at data. And I mean, to the point where my family would be like, we're here. But I don't know, like the way it's set up, and maybe it's because I am working acute care where when I leave, there's another provider there for the
Right.
next 12-hour shift or whatever. So when I leave, I don't think about it anymore because, just like you did when you were an RN.
Right.
Whereas maybe if in an office setting and they're my patients all the time, that I would be the same way, perhaps.
Yep. That's something that's been a difficult transition for me to my PRN occupational medicine role because I don't have any follow-up. So I may order an MRI or whatever on the patients. And then I get nervous I can always check an Epic and read the results, but once I leave, it's up to the next provider to follow up on that. So, but again, it's a matter of having those good working relationships where I can text either my collaborator or the other physician, one of the full-time NPs who I'm really have a great working relationship with them. Like, hey, this is the follow-up, or they'll text me and be like, hey, what do you want? This guy's back. What do you want to do with him? And I'm like, oh, sorry. Like if it wasn't clear, I wanted to assess his work status because he went back full duty and make sure his back is not hurting him worse or whatever, so I think it is important to have that, but it is different going to that PRN role and not having, I don't know, your patients could be lost easily, I guess. And that kind of gives me some anxiety as well. But again, trusting the other people that you work with, and they're all incredible providers. So that's helpful.
Mhm.
So
I think it's helpful to think about things that went really well too. You tend to kind of brew, at least me, on the stuff that maybe you felt like you didn't do a good job, or maybe you should have done something more. But then I try to think about the patients that, if I wasn't there, they would be dead, kind of things. So that makes me feel a little bit better. But when you're talking about the call, I just hate call. If
yeah,
you could get out a call, that would be great, because call is really stressful to me. I think it's more stressful than being in the hospital, because in the hospital, you're going to get called. It's not
right.
a big deal. And I do 24-hour shifts when I work at Porter, but LaPorte Hospital, I'm at home, and then I just get called in for emergencies. And I mean, it seems like you just get comfortable in bed, or you're watching a movie and it just starts, and you got your jammies on, you're eating popcorn, and the phone goes off, and you're like, are you kidding me? So
Yeah.
that's my advice to all the NP students. Do not take call if you can get out of it in any shape or
Yeah.
form. I hate call. I hate it.
Yeah. And it's hard. So with me, once we left, everybody went to the ER. So literally that 2 a.m. call could be like a paper cut, not even joking. They would call us about everything, because that's what the medical director wanted, or it could be somebody being flown out because of extensive burns. So you didn't know, you know what I mean? So and then, after you've been on call for like 5 years, my phone would be ringing and my husband would be like, wake up. And I was a young mom, so I would just had fed a baby or whatever, like, wake up. And I'm like, oh, so yeah, it was hard. It was hard. And just after the call, trying to get back to sleep, it could be challenging. And then sometimes they'd call you, 5 times a night for paper cuts, so.
I try to change my ringtone every once in a while, because I start to get like PTSD when I hear that ringtone. So every once in a while, my old ringtone, I'll hear somebody else's phone doing that, and I'm like, oh God, not again. But I'm not even on call, just like, oh, there's the
And
phone.
I have that I have that as my ringtone, so I'll wake up.
It's so funny.
But it doesn't totally like startles you, like, oh my God.
I know. My ringtone for the hospital is the Beatles' Help. And so it's
Oh,
like,
that's funny.
Oh, I love it.
somebody.
You're like, I'm that somebody. I'm here. Well, thank you guys. I think we're almost at an hour. So I just have one last question. So this week's for our 701 students, we talked about APRN specialties. So we talked about the neonatal nurse practitioner, pediatric nurse practitioner, which is going to be Dr. Cavinder. And then in our emerging nursing specialties, we saw critical care listed, which is going to be Dr. Bump. Subspecialties, we had occupational health listed, which is myself. So I just want to talk to you guys. And I think we've kind of already touched on this, but what are specific ways that you prepared yourself for those specialty roles? And how do you continue to keep yourself up to date?
Well, for my, and I'm sure Dr. Bump and Dr. Spain have the same thing. For my certification in that particular, my board, so mine is the pediatric, so it's PNCB. I don't know everything it stands for, but it's the Pediatric Certification Board is what it is. They require you to have so many CEUs. So the state of Indiana for nurses, they don't require any CEUs, but nurse practitioners have to have so many CEUs, and it has to be in your area. So you can't just pick out something that, it has nothing to do with peds. So I do my pediatric, but I also try to do an equal number of neonatal, just because that's where I'm working as well. They kind of overlap, and they will take the neonatal as well, but I like to keep up with the older kids too, because you never know what I'll be doing next. But then, we have the same CEUs, or at least I try to get CEUs for the university as well. So I'm always required to do 15 a year through my certification board. The hospital requires 30 every 2 years. So basically the same. And I just did my credentialing, which I don't know if you've gone over credentialing yet with the students.
Not much. That could be another podcast, probably all in itself.
Yeah, that is a headache. I just tell people never throw anything away. Keep every record you have since birth, and you might be okay. But for that, when I just did my credentialing, they wanted the 30 and I had 80 some. Because, you know, when you have so many specialties, you have to keep up to date on things. And a lot of times you'll get them from conferences. So, you know, we try to pick conferences that have to do with my specialty.
Yeah, I think this is a good point. I just want to add this in real quick before I go to you, Dr. Bump, but for your family nurse practitioner role, so even though I don't see pediatrics, make sure that you are getting your continuing education credits in pregnancy, pediatrics. So I'm always making sure that I am going to conferences and attending those specific lectures as well. Because remember, you as a family nurse practitioner can see from birth to age 120 or however the longest living human being is. So you want to make sure that you are definitely getting continuing education credits in all of those. So
and I'm retired. I'm sure you guys are too, for pharmacology. You know, if you have prescriptive authority, you have to have so many pharm. And then if you have a DEA license, you have to have opiate CEUs too. So I mean, after a while, you know, it's pretty much anything that comes up. I'm like, okay, I'll do that CEU. I never keep track of how many I have. I just keep doing them.
You know, just an aside, I'm reinstating my Illinois license and they are requiring CE in sexual harassment.
Oh,
wow.
Yeah, thought it was interesting.
Yeah.
Anyway.
Yeah. That could be another podcast that's in itself as well. We talked about this last week. So yeah, so make sure that you're staying up to date on those. And I think that DEA, that's a really good comment as well, because that snuck up on me, not with this last nursing license renewal, but with the one before that, because what was it, 3 or 4, I don't know, hours specifically related to controlled substances. So I was like, oh boy, I need to find something. And those can be, in my experience, a little difficult to find. Like I had trouble finding some continuing education on that. So with your DA, you have to have those specific hours. So make sure that you are meeting all those requirements, because you don't want it to sneak up on you. And then I know, so I'm ANCC. So every time I do continuing education, I just plop it in there so that I've got my hours tallying on an ongoing basis. So, you know, I know how many I have, and then, you know, those other things. So publications or whatever, just put those in as soon as you get those done. So, Dr. Bump, specific thoughts, or Dr. Cavinder, anything else on how
I was just going to say, last year I was audited. So, you know, you're not turning in the certificates, you know, you're just telling us how many hours I have. But last year I was audited by the state. And so you have to provide proof, you know, all the certificates you had. So again, don't throw anything out because they want to see each certificate and make sure that it counts for each of the areas.
So a friend of mine who is a program director at another school. It's funny you say that. She just mentioned to me that she heard that the state was shocked at how many, I guess they sent out some kind of mass email, how many people, when they audited them, did not actually have their CEUs done for APRNs. So I was like, oh my gosh. So then I was checking my email. I'm like, did I get that email? I didn't get the email, but again, looking at, they audited more people than normal or something. I don't know. So yeah, make sure that you're keeping up on that. You spend all this time in schooling, and you don't want to mess it up or stress yourself out more, because you can't.
Yeah, because the audit went back 2 years and it was a specific time frame. So if you know, maybe you had them last year but not the year before, then yeah, you were in trouble.
Yeah.
Yeah.
I guess a little different spin on this, being that I do work outside of my specialty, like pretty much entirely outside of my specialty. So I am certified as a family nurse practitioner, and but have been practicing in acute care for the entire time I've been out of school. And I was able to do that similar to Professor Cavinder, because I had experience in the areas that nurse RN experience in the areas, and in our geographical area of Northwest Indiana, it isn't, you know, they haven't really adopted the consensus model. Whereas if when I worked at Rush, I did apply to work as a hospitalist there, and they were not going to hire anybody but a adult gero acute care NP for any inpatient management. So you may be limited in not having the correct certification. And how I prepared myself is that I'm always going to conferences that are going to be, and to attending educational events that are going to apply to the role that I actually work in. So for instance, I go to the Society of Critical Care Medicine Congress. You know, when I go to the AMP conference, I pick out all of the acute care courses. I went to, you know, a difficult airway management simulation class and a central line insertion class, so that I am kind of recreating what I may have learned in that adult gero acute care. But one good thing is that you can go for a postgraduate certificate program. So say you finish your FNP program, and it, you know, one awesome thing about FNP is that you can work across the lifespan, as Professor Spain mentioned. So, you know, maybe you want to do something else for a little while, but you always have something to fall back on then, and can work in anything. Whereas if you choose one area like psych nurse practitioner, you can't work outside of that certification. So I am, you know, starting a post-grad certificate program for adult gero acute care. And so just so that I have the proper credentials, and you know, I'm not going to be limited if, say, I wanted to move and work in the city or clinically.
Awesome. And we are so excited for you to start that program. So congrats.
Thank you.
Professor Bump will be starting her certificate program soon. So it's going to be exciting times.
Very exciting for us, maybe not for you, but
Yeah, we're excited.
like, I'm not going back to school or nothing. I'm done.
We're excited.
I'm excited. I'm excited. I'm always about learning new stuff. I'm not excited about more work, but
Yeah,
it's only a year.
yes,
Good for you.
it's exciting. Well, thank you both so much. So we talked about a lot this evening. I hope our listeners got something out of this in regards to tips for transition to practice. And as always, we are here if you guys have any questions. You know, I'm happy to review, even like people will send me their contracts. Again, I'm not an attorney, but you know, I've definitely looked at some and have had my own position. So we are happy to help you guys in your journey. And then again, just in that unofficial mentor space or official mentor space, whatever we can do for you guys. So thank you so much for listening, and thank you both.
Thank you.
You.
Hang on, guys, I'm going to stop recording.